Hi everyone, welcome back to Next Level Ophthalmology. Today is our second class in Uvea and today we'll be starting with uveitis. Okay, so since uveitis is such a big topic, we'll be dividing it into smaller topics so that the understanding is clear. Today we'll just be dealing with the basics of uveitis. So, to understand uveitis, classification of uveitis is based on its location of primary inflammation. Like the primary site of inflammation, if it is iris and ciliary body, it is referred to as anterior uveitis. Okay. If the primary site of inflammation is the pars plana, then it is called intermediate uveitis. If it is the posterior segment, then we call it posterior uveitis. And then if all the parts of uvea are involved, we call it panuveitis. So this classification is given by Sun group, which is known as standardization of uveitis nomenclature. There is another classification by the International Uveitis Study Group IUSG, which classifies uveitis based on the cause, whether it's infection mediated, whether it's immune mediated, whether it's allergy. So this is the other classification, but frequently you will be expected to understand and know the Sun classification. So what are the types in anterior uveitis? We have iritis, anterior cyclitis, and iridocyclitis. Iridocyclitis means inflammation of both the iris and the ciliary body. In intermediate uveitis, you have pars planitis, posterior cyclitis, hylitis when there is inflammation in the vitreous, and basal retinochoroiditis. In posterior uveitis, we have choroiditis, retinochoroiditis, chorioretinitis, neurouveitis, which means optic nerve inflammation. Then we also have retinal vasculitis. So these are the subtypes of posterior uveitis. Then we have panuveitis, which includes inflammation of all parts of the uvea. So pathologically, based on the type of reaction, based on the type of inflammation, we can classify it as suppurative, granulomatous and non-granulomatous. In suppurative, we have only two types, that is endophthalmitis and panophthalmitis. So mainly you will be expected to understand the difference between a granulomatous type of uveitis and a non-granulomatous. Why do we need to recognize this? Because there are specific etiologies for granulomatous and specific etiologies for non-granulomatous. And that is how we approach the disease and finally manage it. So this table that I show here is very important for you since you won't be having any theory exam anymore. You will be expected to recognize a particular disease based on the presentation. So these are some clinical differences between non-granulomatous and granulomatous uveitis. So first coming to the cause, non-granulomatous or plastic uveitis is usually toxin or antigen mediated and it's usually type 2 or type 3 hypersensitivity. Whereas granulomatous uveitis is usually due to invasion of an organism or due to a type 4 hypersensitivity. So in pathology, if you take the histopathology of the keratic precipitates, you might find polymorphonuclear reaction and lymphocytes. Whereas in granulomatous uveitis, you will find giant cells, epithelioid cells, and macrophages that you usually see in association with the granulomatous disease. How about the onset? Non-granulomatous tends to be not acute in onset, whereas the granulomatous tends to be slow and has an indolent course. So the clinical course is short in non-granulomatous, whereas chronic and has lot of remissions and exacerbations in granulomatous. So the grade of inflammation is very high. So you see a very dramatic response or a dramatic presentation in a non-granulomatous inflammation, whereas granulomatous uveitis is a very low grade of inflammation. So the main difference that comes between these two is the type of keratic precipitates. Okay, in non-granulomatous they tend to be multiple and they tend to be small. However, in granulomatous uveitis you have large Lardaceous mutton fat KP. So these KPs have a volume. They are described to be voluminous. So these are nothing but small granulomas that are seen deposited on the back of the cornea. Now coming to aqueous cells and flare. As I said, the grade of inflammation is high, so you get numerous cells, lot of fibrinous exudates. However, in granulomatous uveitis, all these are a little less. So another important feature that marks granulomatous inflammation is presence of iris nodules. So you can see iris nodules on the margin of the pupil or within the substance of the pupil or even in the angle. So all these things we'll be discussing in anterior uveitis. Posterior synechia. So posterior synechia are nothing but adhesions that are formed between the anterior capsule of the lens and the back portion of the iris. So these tend to be thin and tenuous in non-granulomatous uveitis, whereas they're thick and broad based in granulomatous uveitis. Okay. So posterior segment involvement is more common in granulomatous uveitis. So let us learn a few examples for each of these. More common causes of non-granulomatous uveitis are most common is HLA-B27. So HLA-B27 is a protein and it's associated with many conditions like ankylosing spondylosis, inflammatory bowel disease, psoriatic arthropathy, and all such conditions. So the diseases which are associated with uveitis, these are known as HLA-B27, and this is the most common cause of non-granulomatous inflammation. The others are viral Behçet syndrome and GRA or juvenile rheumatoid arthritis, which is previous name of this disease. Now it is referred to as juvenile idiopathic arthritis. So common causes of granulomatous inflammation are tuberculosis, VKH. VKH is Vogt-Koyanagi-Harada syndrome. It is a granulomatous panuveitis which tends to be bilateral. Sympathetic ophthalmia is again a granulomatous panuveitis that is seen in a sympathizing eye following trauma to the other eye. Okay, then sarcoidosis. So these are common causes of granulomatous uveitis. So tuberculosis here can present with both non-granulomatous and granulomatous type of uveitis. So there are a few terms or few diseases that you will have to understand, and there are some typical characteristic features that you will have to remember. So let's take a question at this point. Match the following types of examples of uveitis with their usual presentation. Sympathetic ophthalmia, Fuchs, uveitis syndrome, Behçet syndrome, GIA associated uveitis. So each of them has a characteristic feature. So let's look at the options now. Sympathetic ophthalmia, we just discussed this. It's a granulomatous panuveitis. So A is 2. Fuchs uveitis is a condition usually thought to be of viral origin, is associated with stellate diffuse capies. Behçet syndrome is associated with a recurrent hypopyon, and GIA associated uveitis is described in presence of Still's triad, which is characterized by fever, joint pain, and uveitis. Okay, so this is the answer, right? This should be A is 2 and B is 3. Yeah, so this is the answer here. So the right answer here is B. So what are the causes of uveitis? Inflammatory, infective, allergic, associated with non-infectious systemic disorders, and traumatic uveitis. So most of our investigations are needed to find out the underlying systemic disorders. Okay. So I have put masquerade in italics here because it's not a uveitis as such. We can call it pseudo uveitis. So if you want to investigate uveitis, you have to first rule this out. So what are the salient features of uveitis? Uveitis is associated with the inflammation of closely lying anatomical structures. Suppose there is inflammation of the iris, there will be some amount of inflammation of the corneal endothelium. So that is why you get those capies or keratic precipitates where the cells go and stick themselves to the endothelium, right? If there is posterior uveitis, there is some amount of vitritis. If there is anterior uveitis, some of the cells spill into the posterior segment and you get spillover vitritis. So there is some amount of mild inflammation of the closely lying structures. So there can be a little bit of inflammation of the rest of the uvea when one part is involved because it's a continuous structure. Okay, and we discussed about spillover inflammation into the anterior vitreous seen in severe anterior uveitis. So when the severe posterior uveitis also you can see some amount of anterior uveitis. So as uvea is an extremely vascular structure, There is high correlation between systemic infective and autoimmune conditions. So that is why we need to involve physicians and rheumatologists when we are investigating cases of uveitis. So there are special types of hypopyon that I want you to know because these might come as MCQs. So hypopyon is due to collection of white blood cells in the anterior chamber. They settle down and form a hypopyon. So this is not infective pus like you see in corneal ulcers or endophthalmitis. So it is more of a reaction. So candy cane hypopyon is usually seen associated with herpes because there is some amount of blood. So you get red, white, something like a candy cane. Okay, there is a spontaneous hyphema admixed with hypopyon. Cold hypopyon is seen in a Behcet syndrome because it's also known as white eye uveitis. There's hardly any congestion. The eyes look very quiet, but there will be a hypopyon. So this is referred to as cold hypopyon. What about inverse hypopyon? Inverse hypopyon is when the hypopyon is in the upper part of the anterior chamber. It is floating. So this is seen in association with silicone oil in the anterior chamber. Silicone oil is used in retinal surgeries and sometimes it can gain access into the anterior chamber. And in such cases, it floats up in the aqueous because it's lighter than the aqueous. Pseudohypopyon is formed by tumor cells. Okay, especially we referred seen very commonly in retinoblastoma. These tumor cells are huge, and pseudohypopyon that you see has a very irregular, bumpy, lumpy kind of a contour. So it's commonly seen in retinoblastoma, primary CNS lymphomas, and multiple myelomas. So this is all for today. So next class we will begin with anterior uveitis. I hope you get something from this class. See you.